Okay, we're going to give everybody a minute to get into Zoom and get ready and getting our YouTube set up. So let's give it another 30 seconds and then we'll get started.
Oops, I think I messed my stuff up.
We about ready? Are you ready, Brenda?
Whenever you are.
Okay. We just want to welcome everyone to our webinar with Brenda Edwards. I think most of you guys probably know Brenda. She's been around MGMA Kansas for a long time. Last time I read her bio and she didn't like that, but she is, according to our little introduction here, she is the queen of coding. You can ask her anything, and if she doesn't know the answer, she will find it. And we are so very fortunate to have Brenda be a part of our organization and help us with the coding. She did previous one on ICD-10 as well as 2021 E&M changes. Those things you can find out on YouTube. And we are also going to have today's presentation on YouTube. So you or anyone in your organization can go on another day and look at it and watch the whole session of Brenda presenting for us. Just want to remind you guys that we do have a scholarship going on right now, and it is set up so any new individuals wanting to join MGMA Kansas, someone is put up some money, and so you only have to pay half of the cost for your membership. So if you're interested, send your membership information in, I guess. I think it's how it's working. And we will have the scholarship then pay its portion as well. And so that's a really good deal. If you know anybody that wants to join, might as well do it now. I think we've got 6 left. And our sponsor today is Blue Cross Blue Shield of Kansas, and they're a longtime gold sponsor for our organization. And we thank them for sponsoring this, and that just helps us tremendously. So Brenda, I'm going to turn it over to you, and you go ahead and take over. One thing I do want to add, the slides are not out there yet on the MGMA Kansas website. They should be out there later today, hopefully, or tomorrow. So you're not going to see any slides until later today or tomorrow. But Brenda, I'm going to go ahead and turn it over to you. And again, thank you so much.
All right. Welcome, everybody. I think we are all ready for, excuse me, 2020 to end. How about you guys? I know I am. So, and it's my fault you don't have handouts, and that's because Phil hasn't killed me yet, but I sent my presentation to him about an hour ago, and that's because a lot of you are aware that the final rule was released December 1st, not in the Federal Register yet, but there was some information there that I wanted to add to the presentation. So we have a beautiful new logo for our new company now, instead of just plain old slides like last time. Let's get rolling. And I've got the chat box up, so if you guys have questions, feel free to put them in there. I'm going to give you the disclaimer that I always do when I do these updates. I am not the expert on everything CPT, or anything for that matter. The changes this year are not too terrible, but when we get to this lab section, Path and Lab, and some of these proprietary analysis things, I am not your person for that, but I will give you any information that I have access to. So what's new for this year? 329 new changes, 206 new codes, 54 deleted, and 69 revised. Excuse me. 10,623 codes in the 2021 code set. No, I did not count them. That's what the AMA says. This breakdown, and I find this kind of interesting because I get a little OCD about some of this stuff. This is the breakdown according to the symposium that took place a couple weeks ago. As I was going through this, I would find my numbers didn't quite jive with, what they're saying were added or deleted. So I'm just going to forewarn you, if you're into counting all of these, you're probably going to have some discrepancies too, but it'll be okay. So I've tried to do it this way this year, that anything in green boxes are the new codes. Anything in a red box is deleted, and the changes, revisions, are in an orange box. Okay, so I'm not going to spend much time at all on E&M because we had that separate session with all of the changes coming to the 99202 to 215. Remember, 201 will be deleted as of January 1st. That's because counting just medical decision making, it has the same decision making as what the 99202 has. There are revisions, though, in the text of that code group, as well as prolonged services, prolonged clinical staff, and complex chronic care management. Our new code 99417 had just been announced, I believe, right before the last webinar that I did for you guys. This is the prolonged service that is used specifically with the 99205, 99215. And this is the code that CMS did not have agreement over the use. So we now know that we are going to have G2212, which will be the CMS code to use for 99417. The other new code is 99439. This is chronic care management, following elements that are listed, and it is for supervision of clinical staff time directed by a physician or other qualified healthcare professional. So quickly on the 99417, remember that AMA wants floor time, meaning once you are at 75 minutes, 74 minutes is the maximum for 99205. Once you're at 75 to 89 minutes or greater, you can start billing 99417 for each 15-minute increment. So it's a full 15 minutes. For the 99215, the maximum is 54 minutes. So once you hit 55 minutes, then you can start billing for those increments as well. For CMS, our G2212. So we're going to have to get to 74 plus 15 minutes. So 89 minutes to be able to start billing the add-on code for prolonged services for 99205, and for 99215, we have to be at 69 minutes to bill it. And again, remember, it has to be 15-minute increments. It's not fractions of time. Anybody doing anesthesia? Woohoo! Nothing changed this year. And I think because we have so many E&M changes and COVID, that the rest of the changes have not been near as extreme as we've seen in previous years. So overall in surgery, we only had 11 deleted codes, 28 revised, and 11 new. We're going to go through. So I have each of these colors. So the orange are going to be those that have revisions. And I've tried to bold the changes in the language. If you have gotten your new CPT book, you can follow along in the changes in the appendices, and it has everything underlined that's the change. So these are all the breast codes, and instead of mammary as a term or mammoplasty, now it's changed to breast. The other change are the wording from prosthesis has been changed to implant. So you can see on here where the changes are, if these are codes that you're using frequently. The language has changed, the content has not. So you're still reporting the same service, just with updated language. 19324 and 19366 have both been deleted. And 19324 has a reference to use 15771 to 15772. The rest of this slide are additional changes in the breast codes. Some of the additions, like on 19364, are the different types of flaps being listed out, as well as that taking place on the other codes. The single pedicle is been clarified in the language for a lot of these codes. And then you'll see down at 19371, it's a complete capsulectomy, removal of all intercapsular contents. So moving on, musculoskeletal, we had a couple of changes, and that is in the arthroscopy shoulder codes. Again, the bolded information is the new language. Content, again, is not going to change. So this is for debridement, shoulder limited or extensive, and it's defining one or two discrete structures. Those are listed out, as well as the 3 or more discrete structures. So that should make, I know shoulders and knees are very difficult to code the different compartments or areas that they're accessing. So this language should help to clarify that. In the respiratory section, a couple of new codes, a repair of nasal valve collapse. And then in the lung, 32408 is core needle biopsy, lung or mediastinum, percutaneous, including imaging guidance when performed. As in previous years, we're going to see the codes that are utilized most frequently together, 75% or more of the time. We're going to start seeing these become component codes where, for example, here we have the needle biopsy as well as imaging all into one code instead of reporting that separately with the radiology code. And then we have 32405 and 49220. These were both deleted. The 32405 being replaced with 32408. Lots of changes in cardiovascular, not new, but changes in the description. So these are all specifying left heart, right heart, or both in the 33990 through 33993. 64455. I mean, look at how far we jumped from the cardiovascular all the way to the neuro codes. Change in some of the language here. Again, it's identifying the specific digital nerves. For 64455, the plantar common digital nerves, example of Morton's or neuroma. And then on the remaining codes, the 64479 through 84, these all have changes in the language so that the transforaminal epidural with imaging guidance, which is fluoroscopy or CT, has been changed. And that's reflected in all of those codes, and it's based on the level of the cervical or thoracic lumbar sacral levels or the additional levels. The new codes for cardiovascular, typically when we have a new code, it had been a category 3 code. That was a temporary code for 5 years. So typically when they hit that sundown time period, then they're going to either become a real code or will be sunsetted. So we have 741, transcatheter atrial septostomy, so TAS. This is specific for congenital cardiac anomalies to create effective atrial flow, including all imaging guidance by the proceduralist when performed any method. So that's going to include imaging the procedure. Again, instead of billing out the components of the radiology separately, it's included in this code. The 33745 is transcatheter intracardiac shunt, so TIS, again for congenital cardiac anomalies. And it has everything listed out that's included here, and that's left and right heart diagnostic, cardiac catheterization for congenital cardiac anomalies, target zone angioplasty, and then any of these additional when performed. And then that is for the initial intracardiac shunt. The 33746 is going to be for each additional intracardiac shunt. 33995, insertion of ventricular assist device, percutaneous. This is another one, including radiological supervision. And then the 33997, that's the removal of the ventricular heart assist device. And that one is noted, it's a separate and distinct session from the insertion. Genitourinary, not only new, but then also our deleted codes, the 57112, vaginectomy has been deleted, and 58293 have been deleted. That's the vaginal hysterectomy. New codes, 55880, the ablation of malignant prostate tissue transrectal. This is high intensity focused ultrasound. Another code that includes the ultrasonic guidance. And then we have a new code, 57465, in the female genitourinary, computer-aided mapping, cervix uteri during colposcopy, including dynamic, optical dynamic spectral imaging and algorithmic quantification of the ACE to whitening effect. And this is has a list of codes to use it with, so make sure you're verifying that before using it. The ENT codes, we only have a couple of additions, and that is nasopharyngoscopy surgical. One is for a unilateral, and this includes dilation of a eustachian tube, unilateral or a bilateral. So make sure you're aware of those two changes. See how quickly we're getting through this today? Codes that have been deleted in neurology. The craniectomy for implantation, neuroendoscopy intracranial with retrieval of foreign bodies, and then a couple of laminectomies for the cervical level, and the revision mastoidectomy has been deleted. Some of these codes have been low utilization. Some of them may have been outdated procedures when they're deleted without being replaced. In radiology, we have just a couple of deletions. Ultrasound follow-up study has been deleted. And then red cell survivor study has been deleted. Some changes in the computed tomography for thorax. This is diagnostic with or without contrast material. And then the third code is without contrast, followed by contrast material and further sections. So that layout is very similar to the previous CTs that we already have in existence. And we have urography antegrade, 74425, and 76513 has been revised for unilateral or bilateral in the ophthalmic ultrasound. New codes, the CT thorax low dose for lung cancer screening without contrast materials. So make sure you're aware that is specifically for the lung cancer screening. And then we have 76145, the medical physics dose evaluation for radiation exposure that exceeds institutional review threshold, including report. Now, while we're sailing through all this so quickly, we're gonna get to a couple sections that's gonna slow us down. So don't get too excited that we're moving this quickly. Path and Lab has had many changes in it, surprisingly, right? No. A lot of that's due to COVID. Part of it is due to the proprietary analysis codes. So let's look at some of this. 81545, oncology thyroid. This one has been deleted. There are revisions in a number of codes that I have listed here. And again, I've bolded the words that have been changed. The molecular pathology level 2 through 6 has parenthetical information that's changed for all of those codes. So if you are using these codes, make sure you're referencing the CPT book to see what those particular changes are. They were pretty bulky. 82075 has been specified that the alcohol ethanol is by breath. The other is serum that's already there. And then 82670 has been clarified that it is total estradiol. We have a number of new codes. And so keep in mind when we're adding some of these, if they are for quantification or if they are quantifying the amount or if they are looking at the quality or quantity. So you can see here we have some familiar names: acetaminophen, carbamazepine, salicylate. There are methotrexate's another one. So these are all going to be new codes, as well as a lot of this, which I am not even going to attempt to tell you about. These are some of the gene therapy codes that are much more specific. My takeaway that I always tell everybody with pathology and laboratory services is if you are not performing the service, if you're simply obtaining the specimen, then you're not going to be reporting these codes. Some of these will be utilized more in the high level laboratories. Again, here are some more of the high level labs. And a whole nother page. We do have some infectious disease codes on here that have been added. This is bacterial vaginosis and vaginitis. A lot of detail in these codes. And then we have oncology, cutaneous melanoma, new code, oncology for thyroid, pulmonary disease, idiopathic pulmonary fibrosis, the alcohol ethanol. This is any specimen except urine or breath. Remember, we had that earlier code for breath. And then the estradiol-free direct measurement. So now we're going to talk some of the COVID-19 labs. One thing I want to point out, and I don't, probably you guys aren't as much of a geek over this as I am, but as I was flipping through my book, my new CPT book, I'm thinking, you know, not a lot of going on here, but what I want to show you is when you get to the laboratory codes, there are multiple CPT assistant information that's been released since the code books have been printed. So your choices are either to handwrite a lot of stuff into your book, or what I did is, these are all out in the free domain right now for AMA. I printed out all of the CPT assistants with the code changes, considered them part of my book, taped them into my book so that I'm not going to miss any of these codes starting January 1st. I have a feeling we're going to be seeing this throughout next year as well, because they have been rapidly adding services to support the labs being performed because it's been such a rapidly changing environment. So looking at all of the codes that have been added, these are added but not in the CPT book. The 87635, that is the detection of COVID-19. 87636 adds that they can also look at influenza type A and B within that test. And then 87637 will cover both the COVID-19, the influenza A and B, and the RSV. So they can report all these multiple services or look for the multiple infectious agents in one lab test. If you guys are members of AAPC, I wanted to point out that there is a really nice article in the December issue written by Ray Marie Jimenez, who's the senior VP, and it also has a nice chart of COVID-19 lab-related charges. And it states the same thing. We're going to have rapid changes throughout the year with COVID. Here's some more of the new codes. 87811. This is infectious agent antigen detection by immunoassay with direct optical. I'm going to go backwards on my slide just a minute. When you start looking at these, those first few words look repetitive, but you have to find those key differences on all the codes. So infectious agent detection and what method. This is by DNA or RNA. On the next page, it's by immunoassay with direct optical, so visual observation. And again, this one starts with just the COVID. 86328 is looking for infectious antibodies, infectious agent antibodies. and that is by reagent strip. That is the for COVID. 86769 antibody, COVID-19. And then 86408 and 9 are the neutralizing antibody. And this is, one is the screen and the 86409 is the titer. And then we have 86413 severe acute respiratory syndrome coronavirus antibody, and that is quantitative. So they're measuring the number of antibodies. The proprietary lab analyses codes are specific to manufacturers. So these are not going to be widely used, but they are new. They are for the different types of tests being performed, like the 0202U is the BioFire products. The 0223U are the QIA products, QIA Gen. 0224U are the Mount Sinai lab, and then 0225U are the GenMark. So again, these are going to be at the higher level labs. Continuing on, we have 0226U. This is TrueImmune, 0240U Expert Express, and then 0241U also is for that. Is this way more information than anybody wanted? This slide I've taken from my COVID-19 presentation that I do, and we have to be watching AMA's website throughout the year. As you can see on this, the CPT assistant, which typically is a separate purchase, you can't access because of the pandemic. These are all out there in public areas. And you can see how many have been released throughout this year for the COVID changes. There is another one at the bottom of this information when you scroll down that tells you about the vaccination codes, and we're going to cover that as well. But AMA has a number of wonderful resources to help with COVID and telehealth. So if you have questions for any of that, that's a great place to look. If you have rural health questions, National Association of Rural Health Clinics is fabulous for that. All right, we're in the medicine section now of our CPT book, and we have a new code 90377 for rabies, and this one is specific to heat and solvent detergent treated. It has to include both of those pieces to be used. A couple of changes in the retina ophthalmic codes, and that is the 92277 changes to imaging of retina or monitoring, and then the with remote clinical staff review and report. These both had been, I believe, worded as remote services before. Now it has that as a component. 92229, new code, imaging of retina for detection or monitoring of disease. Point of care. So now we've got the remote codes and the point of care code. These are all unilateral or bilateral, so either one eye or both. And then some codes that have been deleted, the 92285 and 286, the auditory evoke potentials. One is comprehensive and one is limited. And then the atrial septectomy or septostomy by balloon method, transvenous or blade method. Those have both been deleted. New codes. 92517, 8, and 9 are the vestibular evoked myogenic potential, yet another acronym, VEMP testing. And these are going to be based on cervical, ocular, or cervical and ocular together. So obviously, if you're doing both cervical and ocular, you are not going to report the two codes separately. You'll use the one combined code. Auditory evoked potentials, new codes here. These are broken out for screening, the 92651 for hearing status determination, 92652 for threshold estimation at multiple frequencies, and then 92653 is the neurodiagnostic. Are there any questions so far? Everyone's pretty quiet on the chat. We have some new external electrocardiographic recording. These are all from for more than 48 hours up to 7 days. And so we've got the differences of the first code, including recording, scanning, analysis, report, review, and interpretation. So that's our comprehensive code. Recording only is the 93242. And that one has the notation, it includes connection initial recording. The 93243 is going to be scanning, analysis, and report. Continuing on with this group, we've got the review and interpretation at 93244. 93245 is the review, scanning, analysis, report, review, and interpretation. And then 93246 is the recording. 93247, scanning, analysis, and report. And then 93248 is the review and interpretation. So all of those are the component codes. 94617, the exercise test for bronchospasm has had the addition or revision of language that now is with electrocardiographic recordings. 94619 has been added, and that is without the electrocardiographic recordings. Deleted codes. The expired gas collection has been deleted, the breathing response to CO2, pulmonary compliance study, and then carbon dioxide expired gas determination. Another change in language is the 95070, and that is a tremendous change. If you look at the description, there is a comma that has been changed from a semicolon to a comma. So that's the only change on that particular code. And then 95071 has been deleted. Okay, 99072, I would like some interaction. Is anybody using this code for additional supplies during COVID? And if you're using it, are you getting paid? So I'm going to stop for a minute and let you guys answer that. Come on, guys, you got to participate with me. Linda's not using it. Jane's not using it. Okay, so let me tell you a little bit about it. It is a new code that was established for supplies, materials, clinical staff time over and above those usually included in an office visit or other non-facility service when performed during a PHE as defined by law due to respiratory transmitted infectious disease. So it was another quick addition code, so nobody is using it. Probably a wise move. It is a new practice expense code specifically used for the pandemic. It's only reported when the service is rendered in a non-facility place of service. Oh, Shirley, I can give you some guidance. It's used for additional supplies, materials, clinical staff time required for patient symptom checks, donning and removing personal protective equipment, increased sanitation measures to prevent spread of communicable diseases. So I don't know if any of you have been to the doctor's office lately. I've been a few times recently, and there's a lot of time, a lot of staff time used screening patients as they're coming in. Now, when I go to my provider, and I'm thinking, wow, we probably should have done this all along. They not only are checking your vitals, asking all the questions, but now they're even supplying you with a disposable mask. Makes perfect sense. How do we know how long anybody's been wearing those masks? So there is cost involved in this. So I did a very unscientific poll, and please do not use this for a basis for payment. But here's who's paying. And I just went out and Googled. Blue Cross of North Carolina, no. CMS, no. Blue Cross of California will pay $6.57. Aetna is anywhere from $15 to $30. Cigna's $3.50. Highmark is no. Blue Cross of Illinois will pay $20. Blue Cross of Michigan, no. Blue Cross of New York, $1.82. So you can see it's all over the board for those that do pay. but CMS has said, no, we're not covering it. If anybody uses the code and gets paid, let me know. I would love to see. I did this slide on a national presentation a week or two ago, and some of the people out on the East Coast are getting reimbursed, but the majority are not finding it to be beneficial. Remember, it's in that 99070 category, which we know how they pay for that. Most payers don't even look at that as additional supplies. All right, you want to talk COVID vaccines? I've been hearing lots of stuff on how they're going to get these vaccines out. And I don't know if anybody else has been listening to this, but the vaccines have to be kept at like 100 and I don't remember, 130 some degrees below zero, how they're going to keep them, and in remote areas, get them out and change the dry ice so many times a day. So there's a lot of moving parts going quickly right now. The vaccines, these were released, I think, 2 weeks ago. They will report vaccine candidates that are currently in clinical trials. Shirley says, per Blue Cross of Kansas, records must be submitted to receive reimbursement on the 99072. Well, that's good. We know that they're going to at least consider it. That's great. Thanks, Shirley. The vaccine coding, structure is different than how it is set up for the current vaccines. This is another one that, in my geeking outness, I have taped my instructions right in the book, because it's not going to be here. It'll be 2022 before those additions are made to the book. So you want to be aware of those changes. Let me go backwards. There we go. There are instructional parentheticals that are going to be added throughout the code set that directs users to use that appropriate COVID-19 subsection. It establishes these vaccination codes that are specific to COVID-19 products. And as soon as we get the FDA approval, it will be available and effective to use. This is no different than every year we have some codes with lightning bolts in front of them in the vaccination immunization section. And those are all codes that are expected to receive the FDA approval, but they wanted to get them in with the code set. So here's our two codes. The number sign means they're out of sequence. The lightning bolt means it's a FDA pending code. So the first code, 91300, is severe acute respiratory syndrome, coronavirus 2, COVID-19 vaccine, preservative-free, 30 mcg/0.3 ml dosage. The 91301 is a 100 mcg/0.5 ml dosage. So there's two doses. There are 4 administration codes. The first 2 administration codes are tied to the 30, the smaller dosage, and that is the administration for first dose is 0001A, and then 0002A is the second dose. The 0011A and 12A are the initial and second dose for the 100 mcg/0.5 ml. Handy dandy cheat sheet. We have 2 vaccination codes, 4 admin codes, and this is how it's going to lay out. If you're creative in your CPT assistant, like I was, I've got brackets and arrows drawing everywhere. That gets confusing. Putting it out in a simple format is going to make it much easier. So there's also going to be an Appendix Q. This will be a new addition. It'll identify the vaccine product, the timeline, and the manufacturer. And I've got that little snippet at the bottom of the slide. This is what the layout will look like. It's also going to aid in identifying the correct codes, tracking, reporting outcomes, and it can be used as a resource for healthcare professionals when they're administering the new vaccines and reporting the codes. All of the new codes and dosing will be published in CPT Assistant. So as these new breaking COVID public public health emergency things are coming forward, again, you need to keep track on AMA, whether you're signed up for email updates or just checking the website frequently. Also, you want to be doing that with CMS and any of our payers. Are the doses determined by age? No. And other than, I'm going to go backwards just a second. This is the differentiation, is the 30 mcg or the 100. And let me double check my other. Yeah, I will look, Shirley, but I've not seen anything related to age on these. Okay. 2021 physician fee schedule, and I'm sticking with telehealth on this. We're going to see some changes. We're going to start seeing the CMS telehealth list. If you guys have looked at that Excel spreadsheet, there are going to be a category 1 for codes that will remain in place after the public health emergency. Those are going to be the codes that were there in existence prior to COVID. If you guys remember back, they were very limited, and they were limited to things in rural and FQHC settings. It was not for everybody to use as it is now. I think, though, COVID has really opened a lot of people's eyes that telehealth is beneficial to continue on. I think we're going to see some changes there. The category 2 codes will be scheduled for elimination after the public health emergency has been declared over. The category 3 codes are going to remain in place through the end of the calendar year in which the public health emergency ends. And the rationale is because CMS thinks these codes may have merit for permanent use, but they will need additional data and real life experience to determine that further. So based on this, category 1 has some new codes that are going to be added. That is the group psychotherapy, physiological, neurophysiological testing, domiciliary rest home custodial care services for established patients, home visits for established patients, cognitive assessment care planning, and then prolonged services G2212. That's the code, remember, at the beginning of the presentation when we talked about 99417 for prolonged services for 99205-215. This is the Medicare code that will be used instead of the 99417. These are all the category 3 codes that will stay on the list to see if they are going to be permanent use codes. And I can already see I got trigger happy with 999217, the very bottom code. That should be 99217, sorry. But you're seeing a lot of similar things, the domiciliary, home visits, ER, nursing facility, therapy services for PT and OT, hospital discharge, neonatal critical or intensive care, critical care, end stage renal disease, and then subsequent observation discharge day management. There are category 2 codes. We have a revision of 1 code, no new, no deleted. Category 3 has a number of deleted and revised codes, and I'm going to be honest with you, I've got them listed out here in the slides for you. I did not, in fact, I'm waiting for my CPT changes book with all of the rationale in it for any further explanations. Normally, I like to try to give you tidbits in this section of some of these new procedures. So if there's anything in this list that you see that you want more information, email me and I will get that to you as soon as I have more information to back it up. There's some new CT breast codes with 3D rendering, quite a few of those. The PLA codes, these are the proprietary lab analysis codes. There are 85 new codes in this category, and oops, sorry, I did not list all of those out. Those are that code group that are more restrictive. Shirley's asking, how do you do critical care via telehealth? And the answer is, you may have an individual acting on your behalf in the hospital. I call it virtual scribe. Your person on that's bedside is your hands-on while you're not physically there. So it could be a nursing staff using real-time, whether it's an iPad, computer, whatever, but it's two-way audio visual. And it is really, I guess, more of a consultative role to utilize that service. Okay, any other questions? I am at the end. For once, I'm actually finishing early. Any questions on any of the code set, COVID? I was going to mention, I didn't get it in here, that the conversion factor is dropping $3.68. So it will be $32.41 instead of $36.09, which where we were this year. Any questions, or anybody have anything to cuss and discuss? If not, Phil, I turn it back to you and Denise. Denise can't hear you. You're mute. Shirley's asking, are the RVUs dropping for E&M? I've not seen that. I've just seen that the conversion factor has dropped. You there, Denise?
I am. Any other questions?
I would like to mention that the slide documents or the slide presentation has been placed on the website, as well as the E&M changes, the additional slides from Brenda's E&M changes webinar. So I placed that in the chat, and those are all available through our website, resources, documents, and under Brenda Edwards documents. So
Great.
Ooh.
Thanks, Phil. Okay, just a reminder, Thursday, December 17th will be our next webinar, and that is latest legal concerns. And that's with Kyle Galvin. He's an attorney, and I think he's going to be focusing on telehealth. So we look forward to seeing you guys again there on the 17th. Don't forget, this will be on YouTube. Make sure that you go out and subscribe to our YouTube channel, so we can keep these webinars out there for our people as well. And so if nothing else, then we will see you December 17th. Thank you.
Thanks, everybody. Have a good day.